Assalamu alaikum warahmatullahi wabarakatuh. Our talk today about prostatic tumors. The carcinoma of the prostate, the most common, is adenocarcinoma of the prostate and is the most common form of the cancer in the men. From the name adenocarcinoma, this is a carcinoma and contains glands. Pathogenesis: androgen increase the risk among first degree relative of patients with prostate cancer. Highest among African American will be aggressive, clinically significant type is more than American. Environment also has effect a risk factor for the pathogenesis of the adenocarcinoma. Acquired genetic mutation also is the risk factor. TMPRSS2 ET fusion gene mutation. This occurs in approximately 40% to 50% of prostate cancer. Other mutations lead to activation of oncogenic PI3K active signaling pathway. This is the most common mutation that inactivates the tumor suppressor gene B10. Morphology. The morphology under the microscope or grossly will be firm gray-white lesion with ill-defined margin. Is it a carcinoma? That means ill-defined margin that infiltrate the adjacent glands. Most lesions are adenocarcinomas that produce well-defined, readily demonstrable glands pattern. The glands are typically smaller than benign glands. Always compare between the normal shape of the tissue under the microscope and the abnormal one to differentiate. Okay, the adenocarcinoma will be smaller than benign glands and are lined by single uniform layer or cuboidal or low columnar epithelium. Usually the prostate, we said before, has two epithelial layer, right? In adenocarcinoma there will be just one single uniform layer of the epithelium. The outer basal cell layer, typical of benign gland, is absent. Malignant glands usually crowded together and characteristically lack the branching and papillary infolding like in normal glands or in benign conditions. The cytoplasm of the tumor cells range from pale clear, as in benign glands, to distinctive dark purple appearance. Nuclei will be large and often contain one or more prominent nucleoli. Look to this picture, contain abundant of the glands, this low power, under the microscope, show different smaller glands and crowded, okay, and dark color of the cells. Observe this purple color. This high power, observe the nucleus of these glands, purple, and there is prominent and abundant nucleoli. Clinical features, usually asymptomatic lesion. 10% of cases has pain in the back due to skeletal metastasis. When we do rectal examination, there will be hard and nodular gland fixed to the surrounding tissue. If we do a tumor marker, serum prostatic specific antigen measurement is used widely as a cancer screening test with limitation, but has clear value in monitoring progressive or recurrent prostate cancer. It may infiltrate the seminal vesicles, periurethral zones, adjacent soft tissue, the wall of the urinary bladder, or the rectum. These all adjacent structure can be infiltrated by this adenocarcinoma. Bone metastases are frequent late in the disease and cause osteoplastic, that's mean bone producing lesion. This is a picture of skeletal invading by adenocarcinoma of the prostate. Clinical evaluation do a tumor marker, prostatic acid phosphatase or prostatic specific antigen. We can do radiology to see the metastasis to the bone, prostatic needle biopsy, this for sure, to see the prostate under the microscope. We talk about it, bone scan. Management, either hormonal therapy or transurethral rectal prostatectomy or radial prostatectomy or radiotherapy or chemotherapy instead of invasive carcinoma. But in local lesion, we can do transurethral or radical prostatectomy. That is all. Thank you so much.